esteemed faculty also. The college faculty are welcome to give their inputs. Now, Sankalp webinar was actually conceptualized during the pandemic, because that is when postgraduate education took a very big beating, and we thought that family planning issues should be taught to our teachers one-to-one. And very fortunately for me, Dr. Lakshmi Shrikande, the chairperson of ICOG now, has agreed to continue this under the FOGSI ICOG banner. And I'm very grateful to Dr. Shikesh Pai, the FOGSI president also, for having endorsed this series of webinars. So this is the first session today. At the outset, I request the provider to play the invocation song, and after that I will invite the chairperson to give a few words on the launch of this. Can we have the invocation song, please?
Komal?
Yes, ma'am, just play.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
Yeah, thank you very much. I can see that the hierarchy in ICOG, Dr. Lakshmi Shrikande is here, the chairperson. I request Madam to say a few words in encouragement. Thank you.
Thank you so much, Shobha Gudi. And I know you are the brain behind this Sankalp series. And I'm really happy that this time FOGSI ICOG is a partner in this Sankalp webinar. We know that India is the first country who has a national program on family planning, and that was started way back in 1952. And now, not only for population stabilization, but this program is working towards reproductive health issues and also to decrease the maternal, infant, child morbidity and mortality. And I'm so happy, Shobha, that you are involving all the postgraduates and medical college teachers, because now in this family planning program, many newer contraceptives have been added. And if postgraduates and our teachers, fellows and members are sensitized towards what we are having in this basket, it will be a great boon to the woman whom they are catering. And yes, of course, still the male participation is way behind what we all expected, and non-scalpel vasectomy has still not, I mean, popularized or whatever. There are myths and taboos, and it has not become popular. So I'm sure with this Sankalp series of webinars, we will be able to address these issues, and we will be able to help the government of India as far as their national family program is concerned. And I can see I welcome Dr. Parag, who is Vice Chairperson, Dr. Ashok, who is Secretary General of Secretary of ICOG, and of course, Shobha Gudi, you are the convener of this program. I also welcome all the faculties and the postgraduate students, and I can see many teachers from the medical colleges. They have logged in, so I welcome all of you, and I hand over the proceedings to Dr. Shobha Gudi for the scientific session.
Thank you so much, Dr. Lakshmi, and I must congratulate you on your thought processes, because you immediately saw the potential of this program and you gave me the opportunity. I'm so very grateful for that. And as elected member of the Governing Council of ICOG, it is indeed a blessing for me that I am able to do this series, and I take along with me many other staff members who have come forward to support me, many other governing council members. Thank you so much. I now request Dr. Parag Biniwale to say a few words, since this is our launch session. Dr. Parag, wonderful to see you here. He's the vice chair.
Thank you, Dr. Shobha, Chairperson, Dr. Lakshmi Shrikhande, and dear friends. It's indeed a pleasure to be present here, though I'm still in the hospital, so with my mask on. But this is something which is really important for the postgraduates to understand, that family welfare is an essential and integral part of obstetrics and gynecology. And we as caretakers of women have to understand the details of family welfare programs, family welfare modalities, and how to implement it. So my best wishes for the program. So thank you, Shobha, once again for initiating this, and I'm sure I join hands with Lakshmi to, we all should propagate this ahead to more and more medical colleges. Thank you very much.
Shobha,
Dr. Yeah, Dr. Ashok, secretary is here. Dr. Ashok Kumar.
Ashok, can you unmute? Are you? He had logged in, but now I can't see him.
I'm not able to see him.
Yeah, so let's start with the program.
Yeah, let us start with the program. I will just, Dr. Lakshmi, I would just like to kind of, welcome the HODs of
Yes,
this
please,
today's
please. Yeah,
who have, and I think starting from Dr. Reena Vani from
Yes.
Cooper Hospital, who agreed to, bring in her students, and also Dr. Geeta Balsarkar from Wadia, and Dr. Saumitra Inamdar from Nagpur. I must get the list in front of me to do justice. 1 minute, I'm just getting the program in front of me. And I think NKP Salve Institute of Medical Sciences, Nagpur, Dr. Anuja Bhalerao, AIMS Nagpur, Dr. Suchitra Mundle, Shalini Tai Mege Hospital, Dr. Saumitra Inamdar, Government Medical College, Nagpur, Dr. Manjushri Vaikar, Indira Gandhi Government Medical College, Nagpur, Dr. Uiki, Cooper Hospital, Mumbai, Dr. Reena Vani, Wadia Hospital, Dr. Geeta Balsar, Grant Government Medical College, Mumbai, Dr. Ashok Anand. I did see Dr. Ashok Anand a few minutes back. I hope he is still there. Lokmanya Tilak Medical College, Mumbai, Dr. Arun Nayak, St. George's Hospital, Mumbai, Dr. Rajeshri Katke. This was the team that I was able to contact and bring together, and these are the HODs who
Yeah, and
connect.
Shobha, I can see
Yeah.
not many teachers from Nagpur who have logged in. I can see Dr. Rajashri Sengupta is here, Dr. Maushmi Tadas Parpillewar was here, Dr. Rujuta Fuke is here. So there are many teachers. I'm so happy that teachers have logged in, and along with them, the postgraduates of their respective medical colleges are also here.
That's a great thing.
Yes.
That is great. I will just start with a preliminary presentation of introduction, following which we will take up the subject matter. I'll just share my screen after opening the PPT. Yeah. I think I will just take 5 minutes of your time in introducing the concept and why exactly postgraduates should be so tuned to family planning when it comes to family planning, reproductive planning. It is a concept, it is a philosophy in life. It is not only limiting of children. It is a concept, it's a philosophy, is what I have always propagated as chairperson of the committee. Now, it is not a special privilege. I hope everyone can see my screen. Is my screen visible, Nilima?
Yes, ma'am, it's visible.
So thank you, Riju. Thanks a lot. So it's family planning services are not a privilege, but a basic human right. And it should reach that last mile in our peripheral obstetric services, and no client in need should go unserved. So the future generation of obstetricians and gynecologists should know that, this is very, very important, and it's an integral part of your service. So this slide is showing the evolution of the family planning programs in our country, as Dr. Lakshmi very, very correctly pointed out that it was in 1952 that the first family planning program in the world was launched in India. So can you see that the governing forces in India have been from the beginning very proactive, and they have always, looked towards family planning as one of the solutions for our problems. But somehow the implementation has not been very robust. But there have been from 1952 to 1976, then 1983, 1994, you can see the various programs, and there may be a question on what is the evolution of family planning program in your country. You may be asked that, and you can see that the several milestones that are there. For example, 1996 was target-free approach. 2000 was second national population policy. 2012 was NRHM, which got extended to 2017. Like that. And then we have FP 2020, and then we have FP 2030. So please understand that there is a lot of work which has gone on, and the latest government initiative is for FP 2030, where we intend to aim for a normal fertility rate, 2 and less than 2 fertility rate in all the states in India. So the milestones which have been in place, you have seen, but this is the chart which is showing how much of land area India is, how much of population India is comprising of in the entire world. You can see that 17 to 18% of the whole world population, very close to what China is. But you must also remember that India is a much smaller country than China. So the steepest decline is in the growth rate has been there in the last decade, and this is despite the pandemic. So something to say for the government initiatives. Just a minute. Aparna, just join the thing and my mail I'll open. Just join it, please. Because they're calling up. Just join the people. Talk to them and say that. I'm sorry, there is a parallel link testing from the exam board going on, national board. I had to connect for that. So can you see it here, postgraduates, that the permanent method of female sterilization is still the most popular method adopted by 30 to 40% of our women, and the traditional methods also, the withdrawal method, etc., comprises some percentage, but the focus should be on these spacing methods, on the intrauterine devices, on the plethora of oral contraceptives, of the barrier methods, and the LARC methods. These are the strength of family planning services, because that is what actually is crucial for meeting the unmet need. Now become familiar with this atlas of this map of India. You can see the green, you can see the light yellow, dark yellow, and you can see the red. And this is because there are differential of fertility rates in all these. Can you see that the fertility rate of Indian states, which are in green 1.5 to 2.1. This is called replacement fertility rate. That means one couple, two people in number can have two or less than two number of children. That is called replacement fertility rate. You can see the red states. Focus on the red states. Where is your state? Where is your state? Your state is here 1.8. So you have also achieved replacement fertility rate. But which states have not achieved? UP has not achieved. Bihar has not achieved. Okay? So we have states which are still very high. For example, UP and Bihar are 3.3 and 3.5. Okay? They are the ones where unmet need is highest. So that is how we have to get oriented to the national demography. It is important as obstetricians to be cognizant, to be mindful at all times that population control or stabilization should be one of the parallel thoughts in your mind when you are practicing OB-GYN. So I wish to introduce you all to this kind of literature which is available in the MOHFW website. So if you access the website, you will see a red book on standard and quality assurance for sterilization services, which may be more meant for hospitals than. But this blue book of female sterilization should be read by you. This blue book of this is one kind of sea green. This is blue male sterilization. Then yellow is IUCD for medical officers. Then this for Ayush doctors, which you can forego. But we have a very good book on IUCD for. So this is all available in soft copy on the website as well. So when you are, and then there is this blue book, which is very mandatory, dark blue, Manual for Family Planning Indemnity Schemes. So you know that you all should be aware about what indemnity schemes are running from the government side, because I think it's an important part of your knowledge bank that you should be aware of all this. You should be aware of the RMNCH plus A strategy, reproductive, maternal, and child health and adolescent strategy with equal focus on various life stages. This is the kind of crux of service delivery for maternal and child health from the government. These are all programs run under these 5. Okay? Reproductive age group, pregnancy care, childbirth, postnatal, and family planning. So you can see that family planning is integral to all these services, and actually it forms the basis for all other services. The woman is well oriented inside the family planning clinic. She becomes so much oriented to the rest of the service. So you can see here that this is the matrix, 5 into 5 matrix of high impact RMNCH plus A intervention. So do you know that what happened? So do you know that this drop down of each, this list of each, this is the matter which you need to revise, and this is available very much on the website. You can see this red color here, that is the symbol of MOHFW available. Read it and then become oriented to it. Unmet need in different states. Just get oriented to your state. Where are you? For Maharashtra, here. It's around 6.1, but there are situations, see, Uttar Pradesh, it is so high, it's 25, more than 25. And in Bihar, it is 15, like that. So unmet need is okay in Maharashtra, but it could be better. It could be better. So then existing network of community health workers, they act as a channel for extending services of ours. So you must know that who are the community health workers who are helping in the government strategy, the AJA workers, etc. And the bouquet of family planning services from the government you should be aware of. Postpartum, safe abortion, pregnancy testing kits are being given in the sub-health centers, adolescent reproductive sexual health services are being given, and there is free supply of contraceptives. Now, it may be charged as less as 1 rupee or 50 paisa or maybe 2 rupees maybe, but contraceptive pills, condoms, everything is being given to the community, door to door supply, and that is kind of happening through ASHA workers. So you must know some detailing of how the ASHA network has been placed in this country. It is not only belonging to the P&SM department, even obstetrician should be aware of that. So the programmatic interventions are like this, and the promotional interventions with some compensation schemes. See, excuse me, take the call and say that we will be joining, right? So then here there is, these are the family planning indemnity schemes which are there. You need to know 1A, 1B, 1C. So 1A not able to join. Link is not there, will join. So this, in case of a death, attributable to sterilization within 8 to 30 days from day of discharge, failure is compensated, cost of treatment to the hospital, and the indemnity per dose. So this will be dealt with more in detail by Dr. Malini tomorrow. This is the government basket of choice, and to this you must add Centroman. Centroman as Chaya, and the injectable has become Antara. Okay, so this is the government basket, including male and female sterilization. You should be aware of also of the compensation scheme with accredited facilities. Okay, so I just wanted to next introduce the MET criteria, medical eligibility criteria 1, 2, 3, 4. You should all know that 1 is for that client, for that method in that life situation, that method can be used. For 2, generally can be used with some kind of clinical judgment. 3 should not be used. An alternative should be used. If it becomes very imperative to use, there has to be a very strong clinical recommendation. In general, should not be used. And 4, the method absolutely should not be. So 2 and 3 are relative, and 1 and 4 are absolute indications for use. So this is how the MEC criteria book looks. This also is available online. I must say that the MEC criteria book is very latest one, has been updated with the inclusion of Centroman into the medical eligibility criteria. The wheel looks like this, and you can see that there are this many methods, and there are 1, 2, 3, 4 are listed here, and the life situations are depicted here, and the complications are also kept put here, right? So there are further breakdown of the postpartum will be in this second row. So you will be able to use this very freely if you can understand how MEC criteria is used. So 9 methods are there, and these are some abbreviations which are listed, mainly the drugs, antiretroviral, etc. And then there is emergency contraception pills also has a MEC criteria. And then there is how to use the wheel with clinical judgment and with limited clinical judgment. Please understand. So this is how the base of the wheel looks. The base of, you can see all the methods here, and you can see some asterisks. The asterisks, no, alphabetic asterisks. So if you, for example, you find postpartum and breastfeeding, and you are finding 4F, it is absolutely contraindicated 4 weeks to within 6 weeks. And F is there. So what is F? If you go to F, you find that it is not listed. Maybe I have not seen the alphabet correctly. Okay. Let me look at G, 3G, 6 weeks to within 6 months. So what is G? If more than 6 weeks and not breastfeeding, then it becomes 1. So in breastfeeding women, it is 4, but in not breastfeeding women, it becomes 1. So that is how the clinical nuancing is done. So these are the various situations where we consider using the MEC criteria even in high-risk women, and we are able to give some contraception in every situation. Okay. This is smoking and obesity. This is deep vein thrombosis. You can see cardiovascular diseases. In every situation, you will be able to prescribe in diabetes, in infections, in even in gynecological conditions, in STIs, in several types of anemias, in all types of neurological conditions, even in autoimmune diseases, in cardiac diseases, cardiomyopathy. So I'll be ending by showing you the National Fertility Health Survey. So if anybody asks you about NFHs, you must say that the latest NFHs, the National Fertility Health Survey, is NFHs 5. And that was done during the pandemic 1920 and 2019 and 2020. And that has a lot of data from it, but mainly it is the teenage pregnancy data and from 22 states and the method mix. Okay, so you can see in the yellow that very favorable outcome has been there for teenage pregnancy after the implementation of family planning programs, that there is a decline. And then this shows the family planning indicators change for 90 to 20. You can see that some of the states are still in red. I want to focus on the methods. This is and some of the indices. This is contraception prevalence rate. This is modern contraception prevalence rate. I'm not asking you to read this table. I'm only asking you to familiarize yourself with the National Fertility Health Survey indicators 19 to 20. So this is CPR is not cardiopulmonary resuscitation, it is contraception prevalence rate. And when M gets added to it is modern contraception prevalence rate, it's OCP use. This is condom use, how it was, injectable, traditional method, and the unmet need. Unmet need for spacing has been separately identified, and the demand satisfied by modern method, and the FP program coverage, the health worker outreach for FP, and use were told about side effects. So there are a lot of variables which came out of it. I want you to just become familiar. This is the contraceptive method mix that I was talking about. And it was found that particularly in this NFHs, that injectables have shown a better than the previous NFHs, the previous survey to this survey, the injectables are better. So if women globally used the modern methods, then we can save 218 million unwanted pregnancies. We can save 138 million abortions, 40 million unsafe abortions, and 1,18,000 maternal deaths can be averted if we can do that. So the risk of unwanted pregnancy is more always because it includes abortion, which may not always be safe, higher than the use of any contraceptive, and the answer to that is yes. And that is the end of my talk. And I will now move on to introduce Dr. Rashmi Gupta. Can we have the CV slides, please? Because I think we were not able to do the traditional CV slide one, but I will introduce Dr. Rashmi. Yeah. Dr. Riju Chimota is here. Dr. Riju? Oh. Okay. Somebody is able to share this? Yeah.
Yes, ma'am. Yes, ma'am. I'm here. Sorry, I have poor connection.
I'm able
on
to
my end.
share my slides. I will do that.
Okay. So Dr. Rashmi, welcome. She is the family planning in charge at GTB Hospital, New Delhi, has got a lot of work under her, profile for family planning. Welcome, Dr. Rashmi, and you can start.
Thank you, ma'am. Thank you for a very kind introduction. So the topic that I've been given today is postpartum family planning. So basically here our main this thing is that if we want to have children, it should be by choice and not by chance. So that is why importance of contraception, it is very important. As we have all been listening since the beginning of the session that India was the first country to start family planning. And the good news is that we have already achieved our total fertility rate goal by 2.1% by National Population Policy 2000. Yet India has now become one of the most populous countries, and which constitutes about 17.7% of the world population. 52.5% of the country's fertility is contributed by women of age group 15 to 24 years, and which further contributes to 46% of the maternal mortality. According to the latest NFHS data 2019 to 21, we can see that amongst usage of any methods of 66.7%, postpartum IUCD is only used as 2.1%. So we know that there is high unmet need of contraception, family planning in the first year of postpartum. And studies also indicate that unmet need for family planning in postpartum period is as high as 65%. And because the fertility returns in the non-breastfeeding women, the fertility return as soon as 4 weeks after delivery. So use of contraception in the first during this period up to 4 weeks in non-breastfeeding women is very important. So also 9% of all pregnancies in a study that was conducted in 2015 to 16, it was found that 9% of all pregnancies were unwanted or unplanned, and a significant proportion of the unwanted pregnancies were aborted, half of which were unsafe, and about 8% contributed to maternal deaths. And as per NFHS 4, the interval between births for women was 32 months, 11% took place within 18 months, 27% within 24 months, yet more than 50% of births occurred within 3 years of previous births. There has been a strong correlation between pregnancy interval and risk of neonatal and infant mortality. And it is inversely proportional. And we can also see that birth spacing saves children's lives as well as maternal risk of morbidity and mortality. If all unwanted pregnancies are prevented, then there is no unmet need for contraception. So it is very, very important to address the women who are already in the facility. So it is very important to counsel them, very important to tell them, and so we can save up to 1 lakh maternal deaths. And spacing is very crucial for at least 36 months after childbirth. And sexual and reproductive health should be a priority as health workers, as doctors. So we are entering this OBG field. So this is very, very important that we should discuss sexual and reproductive health at any point of contact with the women, with the couples, with male, with ladies, whoever are coming in contact with us at any FP clinic, at ANC clinic, any delivery care point, PNCs, and it should be given to maybe never married, pregnant, lactating, contraceptive users. Also, a support is required to them, or non-contraceptive, So coming to the topic, what is
Dr. Saunitra, can you mute, please?
मेरे को ही उसने पुश किया वो
ऐसे दोनों हाथ से फुल फोर्स से दबा के रखा, मैडम जल्दी और डिलीवर हो रही।
Dr. Saunitra, can you please mute your Thank you. Thank you. So postpartum family planning as per WHO is defined as prevention of unintended pregnancies and closely spaced pregnancies through the first 12 months following childbirth. The rationale is, we all know that it is a most receptive period to accept contraception. There is high risk of pregnancy after childbirth. As I just told you that it can be, the ovulation can start as soon as 4 weeks after delivery in a non-breastfeeding women, and unmet need can be decreased, and thus unintended pregnancy and short pregnancy, inter-pregnancy intervals can be reduced, ensuring healthy timing and spacing of pregnancy. So 24 months is a minimum time that is required before a lady wants to conceive. Remember, the best practice is if a woman leaves the facility with the contraceptive method that she has chosen. So if contraception started about at 4 weeks, then there is no need to rule out pregnancy, and there is no need to no need for additional any backup method. And so postpartum period is divided into 4 periods, that is post-placental, immediate post-placental, delayed postpartum, or extended postpartum. Post-placental is up to 10 minutes of delivery, immediate postpartum is up to 48 hours, and delayed postpartum from 48 hours to 6 weeks, and extended is up to from 6 weeks to 12 months. Before starting any contraceptive method, all the ladies, all the couples, they should be counseled, and they should be thoroughly counseled. The counseling process can be started as soon as the first antenatal visit of the lady, and support should be given to her throughout her reproductive life to maintain a healthy reproductive life. And where all we can meet these ladies. So I would say, as health workers, we can integrate our family planning services at all points, maybe when they are coming for adolescent clinics or ANC visits, or any during their delivery also, we can reiterate our messages, or PNC visits, immunization visits, or maybe even pharmacy or the drug shops. And it can be given to all girls, all women, every time when they contact any health worker. Remember, women should never be counseled for the first time about PP-ICOG during active labor, as she may not be able to make an informed choice due to stress of labor. For the counseling, once we start counseling, we have to start with the general counseling. We have to offer her the basket of contraception, as was shown by Dr. Shobha just. So we have various contraceptive methods in the government basket also, and in the private sector also. So whenever a lady comes in contact with us, we have to help her choose the method. We should not choose for her. We should tell her she should be able to choose the method for herself. And further, it is very, very important that we involve the male partner here, or other important family members that may further help her to choose method, and we should not choose the method for her. And whatever method she has chosen, we should discuss the method in detail, which can be done in the method specific counseling. In the method specific counseling, we tell her about the effectiveness, the benefits, the side effects, how to use the method that she has chosen correctly, and if at all she needs additional method for the prevention from STIs, HIVs, and when to return for the follow-up. In the post-insertion counseling also, or post-method giving counseling, we should reinforce the key messages that we have already told her. If she has got IUCD or DIMPA, then the cards may be given to her, in which detailed information about the method that she has chosen are written on it, and her follow-up visit date is also given. And we should emphasize that the client should return anytime if she has any concern or any warning signs. When the patient comes to us, we can ask her about her experience or satisfaction with the method. We should discuss if she has any complaints or concerns and counsel her about them, and explore if she's not happy, then we should explore the reasons for her dissatisfaction. So amongst the various methods, amongst our basket, the methods where there is no hindrance to use are most important is lactational amenorrhea method. If the lady, but here main important point to remember is that she should fall under LAM method. That means she should be fulfilling all the criteria of LAM method that I'll be discussing further. And diaphragm may also be used, but as we know that the size of the uterus changes up to 6 weeks, so we can consider using diaphragm at 6 weeks. Male and female condoms, although can be advised, but they have high failure rates, spermicidal jellies, but along with other barrier methods, IUCD. Yes, it is the best method of postpartum contraception, and can be advised to her in the postpartum period, or immediate post-placental or immediate postpartum period. Male and female sterilization only in suitable couples who have completed their family. And we can also advise them various natural family planning methods, but they are not very effective. So choices which are more efficient, we can tell them to use progestin only pills. Although progestin only pills is available in India, but it is not yet available in the government basket and but injectables, that is DMPA, is available, and implants are in the pipeline to be added in the national basket, not yet introduced. And Sencrumen pills is there, and the methods which are not preferred in the postpartum period are combined oral contraceptives and monthly injections. So talking about LAM methods, these three criteria should be fulfilled for 98% success. That is, the lady should be exclusively breastfeeding, including nights, and she should be completely amenorrheic and up to 6 months of this method is valid up to 6 months after delivery if above 2 are being followed. And I'll be just listing all the methods here, which will be discussed later in the following sessions. So talking about IUCDs, so IUCD in the National Family Planning Basket, we have 2 types of IUCDs, 380A, which is effective up to 10 years, and 375, which is effective up to 5 years. So the mechanism of action is it acts primarily by preventing fertilization. Copper ions decreases sperm motility. It also alters the uterine and tubal fluid environment and creates a foreign body reaction in endometrium, releases macrophages and prevents implantation. The insertion, as I just said, it is post-placental within 10 minutes, immediate postpartum up to 48 hours, and it can also be done in intracesarean IUD insertion before the uterus is closed. So why post-placental and immediate postpartum periods are recommended? Because it is fairly easy to use Kelly's forceps to pass to the cervix while the cervix is already dilated. And why not after 48 hours? Because the cervix begins to close after 48 hours, and also the uterine walls are very soft and it may get perforated, and client safety, we have to ensure the client safety. So we should know that PPIUCD is safe, cost-effective, long-active, reversible contraceptive. It avoids additional anesthesia, antibiotics, avoids additional visits. There is no effect on, which is very, very important point, is that there is no effect on amount or quality or quantity of breast milk. And there is reduced perception of initial side effects, that is bleeding and cramping by clients. And because the lady will already be maybe in lactational amenorrhea, so these perceptions are reduced, and it is a very, very effective method before the lady goes from the facility. But one thing that we have to tell our client is that IUCD does not protect against HIV or STI infections. So we have to tell her to use barrier methods, especially if she is a high risk lady. Next would be contraceptive implants. Implants are effective for 3 to 5 years, depending upon which implant we are using. Then, but its failure rate is 1 per 1,000 users, and they also do not protect against STIs. So additional barrier method has to be told to her to use additional barrier method. And return to fertility is immediate after the implants, and implants can be inserted immediately postpartum, including whenever women leaves the birthing facility. And if inserted before 3 months, there is no need to check for pregnancy. Talking about Chaya is basically the programmatic name for Sancroman. Sancroman is a 30 milligrams tablet or meloxifene, which was launched in 1991 by CDRI. It is a non-steroidal, non-hormonal, once a week contraceptive pill, and it's a selective estrogen receptor modulator. It has a weak estrogenic action on bones and strong anti-estrogenic action on uterus and breasts. It is safe as it has no hormone, and it is very, very safe for the breastfeeding women. And its Pearl index is 1.63. It is a reversible, and return to fertility is prompt. Talking about progesterone-only pills, they are taken continuously every day without a break. Some brands must be taken at the same time, at the same every day, just to make them more efficacious. The failure rate is 9 per 100 users. So POPs do not protect against STIs, including HIV, and so additional method has to be told to the client. And in the postpartum settings, POP can be started immediately in the postpartum period, and POP does not interfere with the lactation. One point I want to stress here is that POPs are more effective if the lady is breastfeeding. The efficacy is if it becomes more effective. Antra is a programmatic name for the injection depot injection of pregnane DMPA. It is a depot injection of pregnane 17 alpha hydroxyprogesterone derivative progestin medroxyprogesterone acetate. Progesterone, it is a progesterone only contraceptive injectable, and it acts by inhibiting ovulation, thickening of cervical mucus, and thinning of endometrial lining. It is a long-acting reversible contraceptive, and it is injected. It is a deep intramuscular injection which is given every 3 months. The dose is 150 milligrams aqueous suspension of DMPA. Injection site, most common sites is the deltoid muscle, and other sites are buttocks, gluteal muscles, upper outer portion, thigh outer anterior. Here I want to, it is very important to know that there are defaulters of DMPA because it has some bleeding problems. It may lead to some bleeding problems. The women sometimes become amenorrheic. Most of the women, they become amenorrheic after 3 months, and there are bleeding disturbances in the ladies. So there may be defaulters. A defaulter is a client who does not return for the next injection on the scheduled date, that is 3 months or the 13 weeks. But she may come in the grace period. So the grace period is if the lady comes 2 weeks prior or 4 weeks later from the scheduled date. This is called the grace period, and we can give the injection where no backup is required. But if a lady comes beyond the grace period, that is 4 weeks after or 2 weeks prior, then she's a dropout if she comes 4 weeks later. So a dropout is somebody who has just come after 16 to 17 weeks, and we have to rule out pregnancy. If she's not pregnant, we can give injection DIMPA if she wants to continue with the injection, or if she has problem coming after every 3 to 4 months, then we should tell her to choose another method, and we can advise backup method for the next 7 days here. So the failure rate is 0.3%. There is no increased risk of congenital anomaly. She can continue pregnancy. Return of fertility can be delayed up to 1 year after discontinuation of DIMPA. This is very important, that if a lady is using DMPA for spacing, we have to tell her that up to 4 to 7 months can be, she can delay her fertility from 4 to 7 months from the last injection. So she should stop her injection counting that. And there are altered bleeding patterns, as I just told you, and it is also associated with small loss of bone mineral density, which recovers after discontinuation. So Dr. Shobha has already told about the medical eligibility criteria, and I want to point here is that in the breastfeeding women, it is MEC1 if started at or more than 6 weeks. Talking about emergency contraception is safe even if a woman is breastfeeding. Emergency IUD is the best form of emergency contraceptive and can be started up to 5 days. And another one is levonorgestrel. It can be used at any time in the postpartum period, regardless of whether woman is breastfeeding or not. Ulipristal single dose can also be, levonorgestrel can be used in a single dose or in the 2 divided doses up to 72 hours. Ulipristal is a single dose, 30 milligrams, can be given up to 120 hours.
Rashmi, can I interrupt for a minute? If you can
Yes,
give the emergency contraception, because the next speaker is going to cover.
Right, ma'am. Okay. So sterilization can also be offered to the women in the postpartum period, and only
this
in
will
a
also be covered tomorrow. So you can briefly touch and you can kind of go towards.
Okay, so I will not be touching here the MEC criteria, and sterilization can be given to couples who want sterilization. Both male and female can be used by the families, and it is important to note that a lady who has just delivered can undergo postpartum sterilization up to 7 days. And this is all these are all the methods that can be used in the postpartum period, like condom, IUCD, and fertilization. They can be used up to immediately up to 48 hours, and can be used as and when for as long as the couple wants to. And male sterilization can be given to a husband at any time from in the postpartum period. Lactational amenorrhea method is used up to 6 weeks, up to 6 months if used correctly. Injection DMPA can be started from 6 weeks, and in the breastfeeding women, POP can be given immediately. Combined oral contraceptive pills are started at 6 months. In the breastfeeding women, and Centroman can be started immediately, and progesterone and injection DMPA or can be started at 6 weeks. Combined oral contraceptive pill can be started in the non-breastfeeding women from 3 weeks, and Centroman immediately. So the take-home message is that unmet need is highest in the first year post-delivery, in spite of 95% of the ladies wanting to avoid pregnancy. So it is a most receptive period to accept contraception. Women can conceive even before the return of menstruation. As I just said, it could be 4 weeks in the non-breastfeeding women. And for limiting the pregnancy, appropriately avoids unwanted pregnancy and its complications. Postpartum family planning is very important, and spacing for 3 years improves maternal and fetal outcomes. Postpartum family planning is not a conventional counseling at 4 to 6 weeks postpartum. It is a continuous process starting at ANC till 1 year post delivery. And postpartum contraception should be provided prior to discharge from the maternity services. So I just want to request all my colleagues to act before it's too late. Thank you so much for patient hearing.
Thank you, Rashmi. You gave a wonderful summary, because everything today has to be called as a summary only. Otherwise, we are not covering the entire portion. We are only giving a sense of direction to our postgraduates as to how to prepare themselves on this subject. So the next speaker is Dr. Archana Base, a very good friend of mine. Rashmi, as the questions come, we will take them up.
Yes,
right now, there are no questions towards this talk in the chat box, but people have been asking whether they can post questions.
Oh,
So
thank you.
I invite Dr. Archana Basir to start her presentation. I don't think I need to introduce her. Madam Archana has been past Vice President of FOGSI, and she is also the Governing Council member of ICOG. So thank you for being here and accepting. And I think as Governing Council member, you will also find it very rewarding to interact with the postgraduates today. Thank you, Archana, and you can please start your presentation.
Thank you, Dr. Shobha, for kind introduction. And may I be allowed to share my screen, please? I think previous speaker, Dr. Rashmi's screen has to be switched off.
Rashmi, can you please stop sharing kindly? Yeah, thank you.
Hi, good afternoon, everyone. At the outset, let me thank Dr. Shobha Gudi for inviting me on this platform and interact with the postgraduate student. I think it's a very good initiative by Chairperson Dr. Lakshmi Srikhande and ICOG to introduce such an important topic like contraception to the postgraduates. I think Shobha would agree with me that contraception is something, though being a chairperson of the committee, Shobha has done a tremendous job, but still contraception is not very well talked about subject in our outpatients. We see the pregnant patients, we see postpartum and all gynec problems, but there are so many windows of opportunity where we can talk about the contraception. So very congratulations to you, Shobha, for really doing a good work on the contraception. I think one of the Dr. Rushali has put her video on, but she's going on a walk. So I'll do this so it will be not disturbing. So, what do you mean by emergency contraception? Emergency contraception should be considered if a woman does not wish to conceive and has had unprotected sexual intercourse. On any day of a natural menstrual cycle, pregnancy is theoretically possible after unprotected sexual intercourse on most days of the cycle. However, risk of pregnancy is higher after UPSI that takes place during the 6 days leading up to the and including the day of ovulation. From day 21 after childbirth, unless all criteria for lactational amenorrhea are met, we had a very good lecture on postpartum contraception recently. We heard that. And from day 5 after miscarriage, abortion, ectopic pregnancy, or uterine evacuation for gestational trophoblastic diseases. After regular hormonal contraception has been compromised or used incorrectly. Copper IUCD insertion after an extended pill-free interval and after a missed progesterone-only pill, requirement for emergency contraception when intrauterine contraception is removed after recent intercourse, pregnancy risk if a progesterone-only implant or levonorgestrel releasing LNG-IUS has recently exceeded its recommended duration of use, and victims of sexual abuse. What is most important thing is whenever a woman comes for in emergency, what all you can offer them as an emergency contraception. These days, with the availability of on the net and in the media, we do get in OPD many girls or women coming to us after having taken the emergency contraception. So it is important to educate women also, apart from our postgraduate, about the emergency contraception. So methods available are oral levonorgestrel. You can give it as a 1.5 milligram single dose. It is available with multiple generic options. Timing of giving oral levonorgestrel is up to 72 hours of exposure. How effective it is? It prevents 84% of unexpected pregnancies. 2.2% pregnancy rate is observed with emergency contraception on oral levonorgestrel. And how does it act? It delays ovulation. It is available over the counter, no restrictions based on age or gender. Oral uripristol acetate, that is 30 milligram single dose. It's a new kid on the block and it can be used up to 5 days. And efficacy is only pregnancy rate 1.4 to 1.9%. That's is observed with ulipristol, and it again works by delaying the ovulation, and it requires prescription. It is not available over the counter. You can offer copper T380 IUD. It is effective up to 120 hours post exposure, and the failure rate is 0.5 to 0.5%, and it prevents fertilization and requires office visit for insertion and variable cost and insurance coverage. It depends. Levonorgestrel IUD, that is available with again different names, but the most popularly used is Mirena. It is available. It should be used within 120 hours. 0.3% is the pregnancy rate. It prevents fertilization and it requires visit to the gynecologist, and the cost again varies. Combination of oral contraceptive pills like 100 microgram ethinyl estradiol and 0.5 milligram of levonorgestrel followed by second dose in 12 hours, that is Usupe regime, which is very common and popular. It prevents 56% to 89% of unexpected pregnancies. Again, it inhibits ovulation and it requires prescription. What are the benefits and risk of emergency contraception? If you take oral levonorgestrel single dose, what are the problems with benefits and the problems? It can resume or start hormonal contraceptives without delay, and decreases efficacy in patients with obesity more than 75 kg or history of malabsorption, like kind of a bariatric surgery. So it's important when you are prescribing emergency contraception to take the detailed history. And it is approved by FDA to be used as an emergency contraception. If you take ulipristol, again, it is effective up to 120 hours, as I have told already. Resumption or initiation of hormonal contraception should be delayed for 5 days. If women has consumed this, she has to delay her regular contraception for 5 days. Decreased efficacy in patients with obesity or history of malabsorptive bariatric surgery. Copper IUD, it is most effective form of emergency contraception, and it can be continued as a long-term contraception. That's the biggest advantage of copper IUD. and significant barriers to timely access, and many patients prefer levonorgestrel IUD over copper T380A IUD, and but it is not approved by FDA. And levonorgestrel long-term contraception, significant barriers to timely access, limited data for use on as an emergency contraception. Combined oral contraceptive pills, like it's a very good dose of OC pills together, so it causes significant nausea and vomiting, and again it is not been approved. If you take copper IUD, it is the most effective method of emergency contraception and should be considered by all women who have had unprotected sexual intercourse and do not want to conceive. It's the only method of emergency contraception that is effective after ovulation has taken place, but is inserted well before the earliest likely date of implantation, so that it does not disrupt a pregnancy that is already implanted. It can be inserted for emergency contraception within 5 days after the first unprotected sexual intercourse in a cycle, or within 5 days of earliest estimated date of ovulation, whichever is earlier. It has advantage of providing immediately effective ongoing contraception if it's not known to be affected by body mass index, weight, or by any other drugs, and there are no like nausea, vomiting kind of side effects with copper T. Oral emergency contraception, it should be offered as soon as possible after unprotected intercourse if the copper IUD is not appropriate or is not acceptable. It is unlikely to be effective if taken more than 120 hours after the last unprotected sexual intercourse, as viable sperms are present in upper genital tract for only about 5 days after intercourse. Has its effect by delaying ovulation? The evidence suggests that oral emergency contraception is not effective after ovulation has taken place. So it is very important to know which cycle of the day women has unprotected intercourse. So likewise, you can advise the emergency contraception. Choosing between ulipristal and LNG ulipristal acetate has been demonstrated to be more effective than levonorgestrel from 0 to 120 hours after unprotected sexual intercourse. It is important to bear in mind that the evidence suggests that both UPA-EC and LNG-EC are ineffective if taken after ovulation. There are also additional factors to consider. Between 96 and 120 hours after UPSI, the evidence suggests that LNG is ineffective if taken more than 96 hours after UPSI. UPI emergency contraception is therefore the only oral emergency contraception that is likely to be effective if UPSI took place 96 to 120 hours ago. So between 0 to 96 hours, the decision as to whether UPA-EC or LNG-EC is most appropriate, it depends on the following factors. The risk of pregnancy from unprotected sexual intercourse for which emergency contraception is being taken, if intercourse is likely to have taken place during the 5 days prior to ovulation, risk of pregnancy is very high, and UPA-EC should be considered first line oral emergency contraception. The risk of pregnancy resulting from further unprotected intercourse, if there is a delay in commencing ongoing contraception, the ability of ulipristal acetate emergency contraception to delay ovulation is reduced if a progestogen is taken in the following 120 hours. It is therefore recommended that hormonal contraception is not started until 5 days after UPA-EC, whereas hormonal contraception can be immediately started after LNG emergency contraception. Recent use of progesterone, the effectiveness of UPA-EC could theoretically be reduced if a woman has recently taken a progestogen. Body mass index, the effectiveness of LNG-EC could be reduced if a woman has BMI more than 26 per square meter or weight more than 70 kg. It is recommended that either ulipristal acetate or a double dose 3 milligram of LNG-EC is given in this situation. It is unknown which is more effective. Enzyme-inducing drugs, the effectiveness of both UPA-EC and LNG-EC could be reduced if a woman is using an enzyme inducer. It is not known whether either method is effective in preventing pregnancy in this situation, it is recommended that a double dose 3 milligram of LNGEC can be used, but effectiveness and how this compared to UPSC is unknown, and use of double dose of UPSC is not currently being recommended. Use of oral emergency contraception, if there has been a unprotected intercourse, and use of oral emergency contraception earlier in the cycle. So there is a evidence that oral EC does not cause abortion or harm to a very early pregnancy. Both UPA EC and LNG EC can therefore be used if a woman has also had unprotected intercourse earlier in the same cycle. Both UPA EC and LNG EC can be used more than once in the same cycle if this is indicated by further unprotected intercourse. What is most important when we are prescribing or talking about emergency contraception is it should include advice regarding the importance of ongoing contraception and information about the available contraceptive methods. So use this window of opportunity to inform a couple about the other available contraceptive methods, which are, like more reliable and which are regular and doesn't put them into emergency situation again. So emergency contraception providers should ensure that after taking emergency contraception and women has access to her contraceptive method of choice. Quick starting of suitable contraception immediately after LNG emergency contraception or more than 5 days after UPA-EC should always be offered, and follow-up pregnancy testing should be arranged. All women requesting emergency contraception should be assessed so as to their risk of sexually transmitted infection, and offered appropriate testing or advised as to the testing that is recommended and how to access this. So there are FRSH guidelines available online, and these guidelines can be really used, like how you can go through the chart. All the postgraduates, they can go through the chart and they can read it out, like more than 120 hours, less than 120 hours, more than 5 days, less than 5 days. So what is to be used, or this can be kept in your clinic also. If a couple comes, like there can be it can be in the form of a laminated thing, you can keep it, and then on that you can advise the patient or the women who is coming to you, like this is the most suitable for you, because you are likely to be asked questions. These days, we are, because women who are coming to us, they are informed, they are going to ask questions about the side effects. How are my percentage? Everybody is into percentage. What are the percentage of me getting the pregnancy in spite of taking emergency contraception? How is it going to work? So we should be well prepared with our answers and with our flow charts to explain to the women who is seeking emergency contraception. This is again another picture of FRSH guideline that can be very helpful in your clinic when you are consulting women and talking to them about emergency contraception. And these are the references from my talk. That is Faculty of Reproductive and Sexual Health Guidelines, March 2017, Improving Contraceptive Care for Marginalized Population by Chris Lauder and all. So in just to take home message from my talk, emergency contraception still stands one method of preventing the childbirth, but it should not be the sole method of contraception. It should be kept for emergency, and women should be advised on regular use of contraception so as to prevent from unwanted pregnancy. So thank you very much for the patience listening.
Yeah, thank you so much, Archana. And it is especially kind of very special because this is exactly kind of the other end of what you practice every day. You are mainly into infertility, but we made you today participate in the family planning webinar. That is very, very nice.
Thank you so much. And I wish you all a Merry Christmas. And if I don't connect with you in between, a Happy New Year as well.
Yeah. Thank you. So we move on to the next talk, and it is none other than Dr. Veena Vani to speak on NARC methods. This is a very important subject because I think long-acting reversible contraceptives are here to stay, and they are actually the key to reproductive health of women. She will be speaking on this subject. Dr. Reena Vani is no stranger to this crowd, a very good friend, an astute academician and physician, a wonderful orator, Reena. She is the governing council member at present, and she has been the chairperson for perinatology committee in FOGSI 13 years back. Reena, I welcome you to deliver.
Good afternoon, and it's a privilege to be here with you all. Can I share my screen?
Please.
Yes. So I would thank Shobha for asking me to speak on this very important topic, which is a long-acting reversible contraception. Because this is a topic very close to my heart, and I feel it is something which we tend to miss or we don't really follow adequately. So coming to that, we are talking about this family welfare CME, and this is the year where our FOGSI president, Dr. Rishikesh Pai, has talked about Badlao. And we've had so much Badlao and changes during the COVID year with our other presidents also. And FOGSI has always focused on women's health. Prevention is better than cure is the old adage which applies so well to contraception. And still we are finding many people misusing abortion as a form of contraception. Vidyano Rupvi Muktaye, through knowledge we shall conquer disease, is the motto of Nair, where I spent 21 years before moving as faculty to Cooper Hospital to become head of department. But what is important is knowing about what are the options available. Even in a city like Mumbai, you have a huge divide. The iconic Taj Mahal, where we are in fact having the current fantastic G20 summit, it's just behind it you have the urban slums. So are we able to give reproductive health services? Archana spoke very nicely about the FRSH guidelines, what she mentioned about. And in COVID, in fact, there was so much loss of services with almost 24 lakh unintended pregnancies, 7 lakh childbirths, 14.5 lakh abortions. But this has not yet changed. NFHS 4 and now NFHS 5 has also come in, is still showing a leaning towards the sterilization. So when we talk about LARC methods or long-acting reversible contraception, we are looking at options which women will be happy to accept, hopefully, as an option to sterilization and also for spacing. In this, we talk about intrauterine methods, implants, and injectables. The copper IUD and the hormonal IUD are the two very, very well-known and very effective intrauterine methods. But as you can see in this summary table, the copper IUD is associated with heavier, longer, and painful periods. We've had a beautiful lecture on postpartum family planning by Dr. Rashmi, and this can also be used post a bottle. The advantage of using a hormonal is where there is a lighter bleed and it is more acceptable to many patients. Implants are gradually making their way, not yet freely available, and require a healthcare provider and are associated with very light bleeding patterns. The injectables are something which have been talked about, and Rashmi beautifully talked about Antara, which is available through our national program. And I will talk about it briefly, but she has already given you a good insight into all this. The main concern with injectables is the unpredictable bleed, or what John Gillibord, father of contraception, has called menstrual chaos, or unpredictable spotting, which is an issue which is not acceptable to a lot of our Indian patients. Amenorrhea and a little bit of delayed return to fertility are other issues. So for the interest of PGs, this one slide sums up all the points which you need to cover when you are asked a question on long-acting reversible contraceptive methods. Now let's talk about the efficacy of these methods and how it compares to the other methods we've talked about. The injectable Depo-Provera or Antara has a fantastic use efficacy. With perfect use, it can be 0.3 per 100 women years, and up to 3 with typical use when they don't come in time for injections and all, which is still better than the failure rate of a lot of the other methods, even with perfect use. The LNG IUD is the same with typical and perfect use, 0.2 per 100 women years. The insert implanon is also the same regardless. So when you look at the medical eligibility criteria for contraceptive eligibility, again, just for the interest of the postgraduates, remember 1 and 2 is where you can prescribe the method, 3 is where there are risks, they may outweigh the advantages, and 4 is where the risks are unacceptable. So you will use the method, and in 3 and 4, you will probably not use the method. So when we select your long-acting reversible contraceptive, first of all, who can administer it? Let's look at the table or the algorithm on the side, on this side. Self-administered options are there, but most of the long-acting reversible contraception require medical, paramedical, or a mid-level practitioner to give them, including injectables. Those for extended duration, we can even train our nurse practitioners to insert the IUDs, and MBBS doctors can also do it. So these are also options. When we talk about contraceptive fit, what do we mean? It is the safest, most effective birth control method, which will work well for the user, depending on her reproductive stage, health profile, lifestyle, and her choice. So the choice is very important, what women want. And medico-legal issues, of course, is something which scares doctors, and we are going to be careful. And the cafeteria approach is what we definitely use. When we are selecting along any reversible contraceptive, this is the basic history, general breast pelvic examination, current medications, duration of other contraceptive use, and then we categorize according to the patient need and MEC. Let's see how our LNG, IUD, and other methods fit into it. The first use was in 1990 with Progesta Cert, which came actually way back in 1976, but that was not LNG. 1990 was with the LNG IUD in a plastic T-shaped frame. As already discussed, it does not protect against STI. Initially, the costs were very high. The costs have gone down appreciably, and now there are many Indian players in the market, and I'm happy to say that it is available quite freely across the country. And not only is there reduction in menstrual flow and pain, there is a reduction in size of fibroids and also of endometrial hyperplasia. In fact, one of the other uses of this in gynecology is in abnormal uterine bleeding. And in fact, people on the waiting list in NHS for hysterectomy, there was a 50% dropout because they were so happy with the LNG IUD which was inserted that they decided not to go ahead with removal of the uterus. We've already talked about the fact that the failure rate with perfect and typical use is similar. And although the insert on the package usually says a lifespan of 5 years, it has been used for up to a year or 2 more. And reversibility is usually pretty quick after removal of the device. Some people have a little bit of irregular period. Small functional cysts may happen. Occasionally, women who are sensitive to hormones may complain of a bit of depression. Injection Antara was introduced in Maharashtra state on World Population Day, which I hope you PGs know is the 11th of July in the year 2017. And we, in fact, it was launched at the Avabai Wadia Health Center. And on the same day, our hospital was one of those who also launched this. And I'm happy to say that day we had a street play done by our own medical students to educate the students about it. What are the facts about Antara? After you stop Antara, 70% will conceive within 12 months. So long-term fertility is not a concern, and up to 90% within 24 months. It can be, in fact, a lot of people had issues whether it can be given immediately postpartum or should we wait for 6 weeks. But now a lot of studies are suggesting it can be given safely in the immediate postpartum period also. As was mentioned by one of the previous speakers, that women may ovulate up to 3 weeks after birth if they are not exclusively breastfeeding. Pregnancy rates range from 0.3% with perfect use to 3% with typical use. Newer injectables like the Depo Sub-Q Provera 104 is a once-a-month injectable with 25 milligram of DMPA with estradiol, and you also have Cycloprovera Cypronate, but these are not being used by us yet. Progesterone implants. The Norplant 6 was the original 6-rod levonorgestrel, followed by Norplant 2 with 2-rod version, which contained 36 or 75 milligram, basically releasing 50 microgram per day. The single rod system with etonorgestrel, Nexplanon, or now etonogestrel, is also available and was given a trial in JJ Hospital. It is going to be commercially available very soon. This etonogestrel subdermal implant is preloaded with a single rod sterile package with a EVA membrane, which controls the rate of dispersal of the drug. In the blue box, you can see the preloaded syringe, which is kind of, it's like a cut needle, which can inject the implant into the correct position. And this is a graph showing the contraceptive efficacy, comparing Implanon with Norplant in the first year and the 5th year. And you can see that the Pearl index is very good and in fact better than Norplant. So when we look at various contraceptive choices, I talked to you about cafeteria choice. What is also important is how determined she is not to get pregnant. So when you look at the graph, look at the ones which have a very, very small blue area. Those are the ones which have almost no first-year pregnancy rates. So the percentage of women who have started with perfect use is the dark blue and typical use is the light blue. You can see there's a vast difference in the temporary methods, but the long-acting reversible methods score over this because there is a very little difference between the two. A little bit about high-risk populations and LARC before we finish. When I say high-risk population, it talks about those who are at extremes of age, lactating mothers, those with medical disorders, gynec problems, with cancers. Now, some of these women, do you really think they would be candidates for sterilization? Or would you be able to use the standard methods for spacing? No. So these are the women where unintended pregnancy itself is an unacceptable health risk, and sole use of behavior-based or barrier methods may not be the best choice. Hence, we should not shy away from it. And in fact, the Indian scenario then and now, this kind of dismal picture where they go to these clinics which are hiding away. And even now, I'm very sad to say that I'm getting young girls with second trimester pregnancies coming for termination who fall into the FOGSI Act, and contraception awareness and availability needs to be improved. In fact, COVID was a major setback, and initially there was a little bit of hesitancy on our part, but when the RMNCH expanded program gave clear-cut advice that we should not shy away from giving services to beneficiaries, including postpartum and post-abortal, even in the COVID period, the scenario improved. Friends, still I'm finding a lot of people are still hesitant to do tubal ligation or to give long-acting reversible contraception like intracesarean. So do not shy away from it, because these are opportunities which are, once they are missed, we will end up with unwanted pregnancies. Adolescents are a very special group who actually should have access to information and pregnancy prevention measures. But here, because of the FOGSI Act, we are walking a double-edged sword, because provision of contraception to somebody below 18 means that you have knowledge of their being sexually active. And as per FOGSI, you are bound to report. If you don't provide her the contraceptive information, you are going to land up having somebody having an unwanted pregnancy and going to a quack. So there are no easy answers to this. We've had a lot of debate and discussion on this. And I hope FOGSI and ICOG will be giving us more clarity and guidelines soon in the guidelines which are going to be put up as GCPRs on our website. So the LNG-IUS with a lower dose can be used in nulliparous women and adolescents. And here I would like to say that I have a couple of my own relatives in the United States in the school or adolescent health programs. The young girls are also being offered the hormone containing LARC, that is the LNG-IUS, as a good option for prevention of pregnancy if they are sexually active, with of course a word about using barriers for safe sex. For lactating women, I will not talk in detail because it has already been covered beautifully by Dr. Rashmi, but these are the standard guidelines based on the MECs where you're having the combined oral contraceptive not as a good choice, and we should also look at the fact that lactational amenorrhea method is very good when we follow the guidelines properly. Women who are breastfeeding can definitely use LNG IUD, and the only thing is the risk of expulsion is more if you go at 48 hours to 4 weeks, which is why it becomes category 3. And definitely if there is puerperal sepsis. Now here I would like to mention, when you've had a PPH, you have done surgical sutures like Heyman, Cho sutures and other things, or a prophylactic, or you've done a B-Lynch. These patients may have a tendency to sepsis. I would be a little hesitant, even if they have given consent, to put in a intrauterine PP IUCD at that time, because some of them do land up with problems and the foreign body reaction is going to worsen the sepsis. This is a simple chart showing the time of use or administration in weeks of various LARC options available. And as you can see, in interval, it is similar. Post a bottle within 3 weeks can be given. Postpartum, again, they have recommended certain gaps because of the expulsion rate if they are lactating. In diabetic women, we know that glycemic control and birth defects are intimately linked. And there was this initial thought that should we be using IUCDs, will they be a source of infection? But if proper asepsis precaution is taken, they are very good options for long-acting reversible contraception. And progesterone-only contraceptives, including Antara, can be used safely in diabetic women if she is not willing for the intrauterine device. In hypertensive women, again, we want to avoid the estrogen. So IUDs or progesterone-only contraception is a contraceptive of choice. In cardiovascular disease, again, please remember, provided you are careful not to have vasovagal attack and you have your antibiotic cover for infection prevention, you will find it is MEC category 3 and recommended by the International Planned Parenthood Federation. And if a woman has varicose veins, which often come up in pregnancy, it can be used safely. But OC pills should be used with caution when there is thrombophlebitis. Women with epilepsy, a lot of the anticonvulsants are folate antagonists. Hence, the IUD and DMPA, both which are forms of LARC, which are required in these women if they don't want to get pregnant, can be used, and they are MEC category 2. Implants and POP may have a reduced efficacy, but injection Antara is used. For liver disorders with cholestasis, we have to be cautious with hormones, and especially if there's an acute viral flare, you can't use the combined pill. Hence, progesterone-only contraception, either injectable and intrauterine devices, can be used as category 1, as can copper pairing device be used. HIV and AIDS is a special group, and we've just finished World AIDS Day on 1st of December. And MEC recommendations for women at high risk of HIV infection. Yes, of course, barriers are important, but effective contraceptive choices such as the LNG IUD, would be very useful, and you have people living with HIV and AIDS for many, many years. Hence, we can advise the IUD because the barriers are in the control of the male partner, whereas the long-acting reversible contraception is in her control, and she is the one who bears the consequences of unwanted pregnancy later. With severe or advanced HIV disease, in fact, it is a little challenging about what to use. She's less likely to get pregnant because if she's already in WHO stage 3 or 4, we can consider medication or other things, but not put in the IUD until the illness has improved symptomatically. So for other sexually transmitted infections, when the infection is active, obviously we are not going to be inserting the device, but once it is under control and she's just a person at risk, she should receive counseling about appropriate behavior and use of barriers, but either category 2 or 3, the intrauterine devices can be used. And again, we should be very clear that there is no protection against STI. Hence, the guideline developmental group has highlighted the need for what we call as dual protection. That is the belt and suspenders approach, where you protect with condoms, plus you protect against pregnancy with some other method. Gynec disorders such as fibroids, endometriosis, here again, the progesterone-only contraception, LARC, can give a treatment option which also prevents pregnancy, and it can be considered. Unless the fibroids are very large, uterus is more than 8 week size, and it is distorting the endometrial cavity, that is submucosal fibroids indenting the endometrium, in which case your expulsion rate will go up, hence it may not work. Obese women, in fact, obesity and diabetes is now becoming the new pandemic, and we have to be careful. But women who are obese can use the LARCs, but women with a BMI which is very high, we have to be careful with any hormones. But the MEC category 1 has been used for even if the BMI has gone above 30 kilogram per meter square. But we need to give them weight reduction and lifestyle modification. Implants and intrauterine device, preferably the LNG IUS, is category 1 for a perimenopausal women. The sex life may not stop just because she has crossed 45 or is perimenopausal. Hence, contraceptive protection along with protection against the DUB of perimenopause will be given by the progesterone-bearing IUD. If she is on other medication, usually 1 year of menopause is the cutoff, after which you can consider stopping it. So I would like to highlight in COVID times what we had done and what we should be doing, which applies today also. We continue with postpartum and post-abortal sterilization services. Contraceptive choices in high-risk population should be taken in a holistic manner. Concerns on all fronts need to be addressed. And in fact, not just in COVID, but even now in certain rural areas, delivery may be the only time the healthcare worker or OBGYN is face-to-face with women. And hence integrating healthcare services and postpartum contraception is important. Correction of anemia, PPUs for the providers, of course, is important. Coming to this fact that it was way back in 2011 that the world crossed 7 billion population. And Danica May was the baby in Philippines and Nargis was the baby in Lucknow who was believed to be the billionth baby. But we are adding 1 more million every 4 days. Risk and responsibility. Would you be more careful if it was you that got pregnant? I would ask the male partner. And we need to have control of all these aspects, look at the psychology of risk taking, prepare for situations, and move towards safe sex. And LARC is one of the very important things. And this little picture at the bottom is our medical students and interns doing the street play with our patients when we launched Antara in our OPD. So friends, spread awareness, spread the message, and bring about a change by better use of contraception in your own hospitals. Thank you very much for the patient hearing.
That was a wonderful, wonderful deliberation. I think many of the faculty who have joined also must have had a very good revision of that, Reena. Thank you so much. And I like the last slide, which actually identifies the risk-taking behavior of our women, especially as far as reproductive health is concerned, and the lack of understanding about the implications, the consequences of unplanned pregnancies. So thank you so much that our young minds, should stay informed about the very single statement if you can make is every pregnancy should be by choice and not by chance. Because chanced pregnancy, the outcome is never, what it should be. Pregnancy should be a delight, and childbirth should be, a divine event, and every child should be welcome. But what happens with unplanned pregnancy is the reverse of all this. So now, if the faculty can stay behind for any of the discussions, I'll be very, very grateful. I ask Radhika to go ahead with the next part of the session. Radhika, you can share your screen.
Yes, ma'am.
Go ahead.
Yeah.
Dr. Radhika Chetan has been a Sankalp champion for me for the past 3 years that I have been working as the chairperson, and very, very proactive about contraception counseling. She is the assistant professor in DMCRI Bengaluru. I welcome her to start our session.
Thank you, ma'am. Ma'am, I'll be sharing the videos today because I think quiz will take longer time. We will play the videos today. Tomorrow.
Video and case-based discussion. Yeah,
yes, ma'am.
Videos.
Videos we will
show
start.
Yes.
Yes, ma'am.
Meanwhile, if postgraduates have questions, start posting them so that I could answer. And if Reena, Rashmi, and Archana are there, they could also, and Dr. Lakshmi also can give her inputs. Kindly post your questions.
Ma'am, you're able to see the screen?
Yeah, we are able.
So I'm going to show the videos of postpartum IUCD insertion. What we use a special technique by using a Kelly's forceps. And we'll also show the video of the no-touch technique of copper T380A insertion. And if possible, we'll go to the implanon insertion video also. So these are the videos we are going to show today. So this is no-touch technique. So this is PPIUCD, postpartum IUCD insertion using special forceps called as Kelly's forceps. Let me know if you're able, if the audio is heard better, or I'll mute it and I'll speak.
Radhika, it is better you speak, I think. It will be quicker. Yeah.
Ma'am, is it heard?
No, it is not heard. You better speak. Yeah.
Okay.
You can continue from here. Yeah.
Okay, so we are after painting and draping, after cleaning the cervix, generally you would have done the painting and draping for the delivery itself. So generally, as the previous speakers mentioned, PPIUCD is inserted within 48 hours, preferably within first 10 minutes of post-placental expulsion. So here we have cleaned the cervix and vagina using betadine. So you are taking the copper T package, check whether it is within the expiry date and package is intact. Take out the measuring card and insert a tube. Keep only the IUCD inside. Keep only the copper T inside within the package. Okay, so this is a special Kelly's forceps, long Kelly's forceps, which is used for postpartum IUCD insertion. So you are going to hold the IUCD between the junction of horizontal and the vertical arm. See to it that sponge holder is not protruding beyond the IUCD, so that it is properly placed within the fundus. Okay, so you start introducing the IUCD into the cervical canal. Okay, and once you introduce into the cervical canal, after passing a while, around few centimeters, you will feel the resistance. When the resistance is felt, then what you have to do is, with the other hand, with the left hand, you have to straighten out the uterine fundus in the upward and backward fashion. So you have to push the uterus in the upward and backward fashion, so that the uterine axis gets straightened out and you will be able to advance your Kelly's forceps into the uterine fundus. Okay, so how do we know that we have placed the IUCD inside the fundus is, you can feel the tip of the instrument with the hand. The whole of the Kelly's forceps has entered the introitus. You can see only the rings are outside the introitus. Only the rings are outside. And with the abdominal hand, you will be able to feel the instrument. That is the one thing. So whole of the instrument is outside. Only the rings are outside the introitus. So after that, you have to open the tongs of the Kelly's forceps. Keep the ends open, come to the lateral wall of the uterus, and keeping the tip of the instrument open, you will take out the instrument. Okay, so once you drop the IUCD, go to the lateral wall, keeping the instrument tip open, and then you have to come out. So when you examine, you will also see that the copper T 380A threads are not visible outside the cervix. That also means it is properly placed in the fundus. So this is IUCD no touch technique of 380A insertion. So the commonly the standard technique which is used for 380A insertion is no touch technique of loading. That is instrument. The copper T is loaded within the package itself without touching even with the gloved hands. And other technique which is used for insertion is withdrawal technique so that perforation risks are reduced. So once you hold the cervix and vagina, clean the cervix and vagina using betadine. Then measure the uterocervical length using uterine sound. Okay, so uterocervical length is measured using uterine sound. Then once you have done painting, draping, and after measuring the uterocervical length, you start loading the IUCD with no touch technique of loading. So when you're checking, see to it that the package is sterile. That is, package is completely intact. It is not opened earlier. It is a sterile packet. Also check for the expiry date. So expiry date on the package refers to the sterilization of the package. Many women come and ask whether we can remove it by another 2-3 years, but it is effective from the day of insertion up to 10 years. So efficacy expiry is only for the sterilization. So for loading the IUCD within the packet, with the gloved hand itself, put the inserted tube into put the plunger into the inserted tube. So first thing is you have a white solid rod called as plunger. This tube is called as inserted tube. Then you have a blue gauge for fixing the uterocervical length. Then IUCD proper. So you have to take out the plunger and put it into the inserted tube till it touches the tip of the IUCD. So put the plunger, solid rod into the inserted tube till it touches the tip of the IUCD in the inserted tube. Then get the IUCD along with the measuring card into the middle segment so that you have space for doing no touch technique. So no touch technique of loading, you are not touching the IUCD with the gloved hands also to reduce the risk of infection and the PID associated with insertion. Okay, so you have to hold the horizontal arms of the IUCD with the thumb and the index finger. Don't try to pinch it. So you have to put a forward or upward pressure using the inserted tube. So once you push the inserted tube in the upward direction, the arms start bending. When they are bent halfway, then you have to pinch them together. So when they are half bent, inserted tube is slightly withdrawn so that you can pinch it completely. Then again with the upward push, you have to place the horizontal arms into the inserted tube. So this is the way of doing no touch technique of loading the copper IUCD into the inserted tube. Okay, so whatever part goes into the uterine cavity should not be touched with a gloved hand. That is the main purpose, to reduce the risk of sepsis and the infection, which is recommended by Government of India, that is NHM. So now it is ready for insertion. So you have to fix the uterocervical length. So for fixing the uterocervical length, you will not move the blue gauge. You have to keep the thumb, index finger pressed on the blue gauge, and you have to move the inserted tube to the 0. So there is a measuring card here. Whatever uterocervical length has been measured, so you have to fix the uterocervical length to the blue gauge. Okay, then it is ready for insertion. So copper has a memory of 5 minutes, so you should not be loaded very early also. So only after painting, draping, and measuring the uterocervical length, only then it has to be loaded into the inserted tube. Okay, so when it is ready for insertion, It is inserted advanced into the externals of the cervix, through the internals of the cervix till the fundus. That is, till you feel the resistance or till the blue gauge sits on the externals of the cervix, it should be advanced. After that, there is a technique called as withdrawal technique. That is, you withdraw the inserter tube. You should not push it with the plunger because it will go and embed in the myometrium, slowly leading to perforation over the years. So you have to withdraw the inserter tube. So once the withdrawal tube is withdrawn, then the arms are going to be released. Okay. Then plunger is removed. Then with the inserter tube, you go and give a second push so that it is properly placed in the fundus. So it should not be pushed with the plunger. It should be withdrawn with the inserter tube. Then the threads are cut 3 to 3 centimeter away from the cervix. Okay. So this is a technique of no touch technique of loading and withdrawal technique for the insertion. I'll share the Implanon video also, ma'am.
Yeah, you can little fast forward it. It should be
Okay, ma'am.
I think we have started at 2:30 and we are 8 to 10 minutes remaining. So I think we can start. Yeah. Quickly.
Okay, ma'am. Just a minute. I'm trying to.
I'm not seeing any questions.
Ah.
1 or 2 quizzes also not there with you today.
Ma'am, I have quiz. PPT is ready, ma'am. So, but I thought it will be late, Anta. That's why I thought only we will play the video.
Sorry, it is for tomorrow. If all the quiz questions are for tomorrow.
Yes, ma'am.
Okay.
Ma'am, you're able to see the video?
Yes, yes, yes.
Yeah. So Implanon is actually a insert which is usually implanted in the upper part of the arm, about 10 centimeter above the medial epicondyle, to avoid the neurovascular bundle. Okay. So you have to ask the woman to flex her arms and keep it above the shoulder level. Keep the arm folded and keep it above the shoulder level. Then from the medial epicondyle, take a measurement. You can use a scale or you can roughly say that approximately 10 centimeter above the medial epicondyle. Okay. Make 2 markings. Okay. 2 dots around 4 centimeter apart because the rod itself is approximately 4 centimeter apart. Okay. So you have to do the disinfection and give local anesthesia. Around 1 to 2 cc of local anesthesia is given along the dotted or the marked line that will be given. So this is the Implanon applicator. Okay, so you should never touch the purple button in the beginning. Only after pricking the skin later only it will be touched. So in the beginning, never touch the purple indicator. So this is the needle with the Implanon. The white dot inside the needle is the Implanon insert. Okay, so this needle is used for insertion basically. So it has to be held horizontally with the thumb and the index finger. Purple ejector should not be pressed in the beginning. It should never be touched in the beginning. So stretch the skin where you have already made the marking and then pierce into the skin with a less than 30-degree angle. So when you're pricking, initially it is less than 30-degree angle. Then you have to lower the inserter. Make it horizontal so that it is placed in the subcutaneous plane. It will never enter the muscle plane. So this has to be lifted. So then once initially it was pricking, it was 30-degree. Now it is completely horizontal to the skin or parallel to the skin. Lift the skin when you're inserting and you will be able to see the needle placement in the skin. Okay, so till the skin comes till the touch edge of the needle, it has to be completely pushed. After this, you have to slide down the slider. Purple slider should be slided in the downward fashion only once the needle is completely inside the skin. So slider is brought back into its completely lowest position. So that will lead to the placement of the Implanon in the skin with the withdrawal of the needle.
So needle is completely withdrawn and the rod is inserted. So you should ask the woman to feel the rod. So this is how it is actually inserted. I'll show you the removal video also. Removal also requires local anesthesia. So removal also requires local anesthesia. About 1 to 2 cc of local anesthesia is given. Initially, you have to palpate the rod and make out where exactly is the tip of the rod. And exactly at the tip, you have to make an incision after giving local anesthesia. So keep the edge of the implant on using two fingers. You have to make it more prominent so that it gets projected into the one dot at one point of the skin. There you make a small around 2 millimeters of incision. A stab incision using number 11 blade is made, and you have to bring the tip of the rod should be made to come through this small window. Okay, so skin and subcutaneous tissue is dissected out using only the scalpel blade. Okay, very rarely you can make out that it is actually embedded. You may need a artery forceps to dissect it out. Generally, only with the scalpel blade, you will be able to take it out. So once it is taken out, see to it that the whole of the 4 centimeter rod is completely intact. Very rarely it may lead to breakage, leading to bigger incision. Ma'am, these are the videos. Ma'am, you are muted. You are muted.
Thank you, Radhika. All now, that was wonderful presentation. Actually, very good videos we have. Of course, you have made a collection over the years, so comes out well when you present it like that. I hope the postgraduates enjoyed, and I want them all to unmute and switch on their video. Those are the correct words. Unmute and switch on your videos so that we can meet all of you. And then ask your queries. Do you have any queries regarding the subject which was discussed today? Openly, because nothing came on the chat box. Let us see if you are there or you have only logged in and you're not there. I'm not seeing anybody. Vidya is there, Vidya Sengotian, Madhuvanti, Vijay Lakshmi Aluri. I can see many faculty are there actually. Deepavali Goswami. Anybody can come on? Sunil, what happened to your PGs? Nobody is coming on. Okay, Vidya has raised her hand, but she is not ready to show herself, is it? Yeah, Vidya. Can you switch on your video? It will be good to see you. Do you have any question to ask? Please unmute her. Provider, please unmute her. Yeah, hello Vidya. Yeah, can somebody unmute her? Try to unmute yourself, Vidya. Not possible?
Yes, ma'am, I can.
ಹಾ ಬರು ಹಾ ಈಗ ಹೊರಡ್ತೀನಿ hospital ಇಂದ. I'm still in the hospital. I'm attending a baby because at home there was no this thing. Now I'm starting now. Okay. So. Hello.
Hello, ma'am.
Yeah, do you have any question, dear?
No, ma'am.
Saumini has also raised her.
Very clear.
Do you have any input feedback to give us? Do you feel that the time was not appropriate? We should start at a later time.
No, it's okay, ma'am.
2:30 is okay.
Very
for
useful for me.
Dr. Saumini, do you want to add anything? Want to ask anything from us? Dr. Saumini, you raise your hand, unmute yourself. Unmute and switch on your video. Saumini. You have raised your hand.
Yes, ma'am. Good evening, ma'am.
Good evening.
Hello.
Well,
Are you
yeah,
able
hello,
to hear me? Yes, are you
yeah,
able
we
to
are
hear me?
able to hear you.
Yeah.
Yeah.
And my small suggestion for the improvement of this continuation of the PPIUCD, ma'am.
Okay.
Postpartum IUCD, because even now I'm working in a teaching hospital with around average of 6 to 9,000 deliveries per year. But still the PPIUCD input is less. So
Which
I
state
was,
is this?
yeah.
Which
So
state?
yeah, in the state of Andhra Pradesh.
Hmm.
I'm working at Visakhapatnam, ma'am. Andhra Medical College, Visakhapatnam.
Okay.
Yes. So it is not the, it requires a team even in the tertiary institute for the continuation of this. Any more suggestions from you for the input to be increased?
Yeah, see, we from FOGSI, we tried to conduct a training program last year. It was
Yeah.
very well received. Our aim was to bring it to the public sector actually. And we tried to bring in participation from public sector doctors in the training program and then start in service. But then, the conviction is lacking in the minds of consultants. They feel it is not very scientific. That is what I could make out. That they feel it is not a method which, it should be done
Because
immediately after
when I had analyzed the causes or the things, I
Yes.
found that discontinuation rate is more, madam.
Pardon?
Discontinuation rate, the removal is more apart from the insertion.
Correct,
They're not
correct.
continuing this
Yeah. And
for
the
a period.
reasons for
Yes.
that is
The reason is they have many things like abnormal uterine bleeding is one their main. So the answer is this. But the continuation of not any methods. And for my one of my postgraduates, I had given Antara as a dissertation for the continuation. But in her series also, the third injection was lacking. Only 2 participants were in the study group for the continuation. So it is the motivation, motivation for the acceptor is also, though we motivate, it should be a constant thing, which I feel.
See, Dr. Soumini,
Yes,
we
ma'am.
have done a multicentric study on PPIUCD. Though the number of centers are more in the public sector hospitals only, because about 7 institutions we could take, and we have submitted it for publication. And we found that there was a very high acceptance rate. 36% was our acceptance rate, and continuation rate was also very good. Expulsion rates were very less. Discontinuation rates were very less. They were both less than 5%. So what should be in place is counseling, and the follow-up has to be very religiously done. And at follow-up also, counseling is important, and troubleshooting is important. So if there is abnormal uterine bleeding, removal is not the answer. We have to manage the abnormal.
No, they're not
And
coming to the
counseling, that
center.
is,
Yes,
yeah,
they're not coming
they
to
are
the
going to
center where
somebody.
the incision was done, ma'am. They're going outside to the various other places because we
Yeah,
have all
so
this.
that is
Yes.
the message we wanted to give it to private practitioners. The message that whenever there is a contraceptive method requesting discontinuation, to go into the depth why, and then offer another method or encourage them to continue. As far as
Yes.
PPIUCD is concerned, once it is put in place, they should be encouraged to, continue at least for 6 to 9 months. And by then, most of the problems will settle down.
Yes.
So that initial hand holding is very crucial. Instead, I
That-
think, I repeat that even consultants feel that it is not a very scientific thing to do. So they tend to remove whenever there is a request, instead of
Yes.
counseling them to continue.
Yes.
So I think these are
This
the
should be
gaps in our
discouraged. Yes.
service. Correct. These are the
Yes.
gaps in our service provision.
Yes.
And the main reason for conducting sessions like this for postgraduates, because they are the consultants of tomorrow. In no time, they will become consultants. Right?
Yes.
So we want
And also
them
the first
to
contact
practice.
person also.
Yeah, we want them to get initiated into correct contraceptive practices. They should be able to counsel well. They themselves should be convinced about the methods.
Yes, ma'am.
That is our effort. That is our
Yes.
So thank you all. Thank you very much for joining today. I can see one chat here by Udayagiri Radha Lakshmi with the DMPA. If patient gets breakthrough bleeding, what drugs can be prescribed? Is Dr. Reena Vani available for responding to this question? Reena? I think I'm not able to see Dr. Reena. Radhika, would you like to take this question? Otherwise, I'll answer. Radhika is there? Rashmi, Radhika. Rashmi, how do you manage antara bleedings? Okay. So since I'm not finding anybody, so then what happens here is whenever there is any progesterone, it's not only medroxyprogesterone, even with etonorgestrel, which is present in implant, is given for a long period of time, somehow the endometrium is not well supported and it tends to bleed in between because there is a lack of estrogen and there is a severe kind of down regulation of the receptors of estrogen or whatever. The endometrium does not do very well. It keeps on bleeding in between. Well, some women perceive it as a very serious problem. Some women accept it. In some women, the symptom is more, and in some women it is very less. So it is very unpredictable how any woman, a particular woman, will behave with the progesterone. So only follow-up will tell us what happens. So when we follow up women with antara and they come with spotting, I think the first approach we do is give them small doses of methylenic acid. 250 milligrams 3 times a day. Even tranexamic acid has been used, but that is considered as a stronger drug. Usually methylenic acid does the job. 3 times a day for about 3 to 5 days is enough, and most often this will stop and the woman is able to continue. If she has recurrent bleeding again, she can use it again, but probably 20 to 25 days apart only, not earlier than that. Suppose the recurrent bleedings are happening very often, then some women may require the use of low-dose oral contraceptive pills for about a month or 6 weeks or maximum 8 weeks or 2 months, by which time the endometrium stabilizes a little more. And fortunately, some women with antara do achieve amenorrhea also. So that is how we need to tackle irregular bleeding. There is also a counseling which goes with all this, is that regular spotting should not be considered as menstruation. And the principal reason why it affects Indian women is because Indian women, whichever community, tend to regard menstruation as an obstacle to offering prayers or having regular religious practices. So we need to inform them that this is actually not menstruation and it is a minor side effect of the drug being used. So even Almighty will forgive them if they do not disregard this as menstruation and go about their work and their prayers as usual. So I think counseling goes along. Okay, Dr. Vidya is telling we use medroxyprogesterone 10 milligram to control the bleeding. Well, already the woman is on medroxyprogesterone. So using again the similar drug probably will, okay. One recommendation is that, already the amount of DMPA released per day is quite significant. One more recommendation for irregular spotting is earlier removal and insertion and injection, re-injection, then the 12 to 14 weeks time interval that we give. So if it is going on happening for 8 to 10 weeks, then we could kind of, stop it. We could prepone the date of the next injection. That is supposed to control the bleeding, because then probably the drug level wanes in some women because of quicker metabolism in them. And that is when, if you give the repeat injection a little earlier, it will stabilize the endometrium then. So these are the nuances of clinical practice which will ensure continuation of contraception. So there are 2 more responses. Okay. Dr. Kiran Chandana. Hi, Kiran. Very nice to see you on this platform. You have written there should be more training program for contraceptive implants. Okay. Good that you brought. Kiran, would you like to unmute and talk? Would you like to switch on your video? I'm not able to see you because. Okay. So implant training is going on in small groups. It is going on. I want to make everybody aware today that Implanon NXT is the implant which is available today, contraceptive implant. It is etonorgestrel 68 milligram, and that is lasting for 3 years, and that is very much available. It is available. It is very much available. And training program is going on from Organon. And the good news is that government also is planning to bring Implanon into the public basket. And that may happen in the course of an year or so. So in a year's time, you may find Implanon joining the Antara and the OCPs which the government is distributing, and the central command, of course. So that will happen. And when it comes to the public sector, then at least training in the public sector will become very robust. But as you saw, the device itself is so user friendly. The needle is especially very, very, very friendly. It just lifts the skin very easily because of the beveled sharp edge, and it's a fairly easy insertion. So training is a must, but at the same time, it's not a difficult skill to acquire. It is something simple, and one needs to have good patient selection, and one has to have a very good outcome of this contraception. Yeah. So I think Radhika also has that. Okay. Then Dr. Vidya again, low dose OCP can start anytime, and how many cycles? Yeah, it can be started anytime. You're talking about the follow-up of DMPA, it can be started anytime. And cycles are, I already said that usually 2 cycles will do the job. And maybe it's rarely may stretch to 3, but 2 cycles usually does the job. Even less than that does do the job. Okay, and that's a job. So I think with that we come to the end of today's session, and we'll meet again tomorrow. So what time shall we meet tomorrow? Can there be some responses in the chat? Do you want it to be 2:30? Can there be some responses in the chat from the PGs? Yeah. Deepavali Goswami, Pradnyas, hello. Dr. Saunitra, hello.
Madam, we have a problem of PGs.
Okay.
And yeah, and if we can make it at 3 p.m., that is quite convenient.
Okay. Okay. I will inform
Thank
Dr.
you.
Lakshmi.
Thank you.
Because she felt
Very nice
2:30.
program, madam. Very
Thank you
nice.
so much.
Very nice.
Thank you. I hope the postgraduates will benefit. For that reason, we
Yes,
plan.
yes. Yes, ma'am.
With that, I think we come to the end. Thank you, Saunitra. Dr. Lakshmi, we will be ending the program for today.
Yeah, please go ahead. Yeah.
Thank you, Dr. Lakshmi. And there is some opinion that it should be 3 p.m. tomorrow. So is that okay?
Yeah, I don't have any problem. We will just inform the tech person, and
yeah,
Nilima will put it in the groups that we are starting at
request,
3.
Okay, thank you. I request the HODs to bring in the PGs by 3 p.m. Today the number was less.
Yeah.
We have contacted 8 institutions, so at least 80 PGs should have come.
Yes, yes.
Correct. So that is less. Please make them join. So thank you again, Dr. Lakshmi, for this wonderful opportunity. And I think as time goes, this was the pilot one.
Yes, yes.
And the previous Sankalp series which I did was during the pandemic. And that is when PGs were having more free time.
Yes, yes.
Today I felt the challenge that, they are not able to join because they will be doing their completion work in the wards, etc.
No issues.
Like that. So,
today also it went on well. Tomorrow we will start at 3 p.m.
Thank you.
Okay.
Thank you.
Bye. Please stop the recording, Komal. Yeah, please. Yeah.
Yes, ma'am.
See you. Bye.